Okay, I'm just going to give it another minute or so here, and then I will make an announcement and hand it over. Okay, let's get started here. Hello, I'm Alex Pond with the UNM Division of Community Behavioral Health. Welcome to today's webinar presentation for Rural Community Psychiatric Residency Program webinar series. Please make sure you're muted during the presentation. If you have questions, please feel to submit them in the chat or unmute if Dr. Kruse opens the floor. If for those requesting a CE or certificate of completion, I will share an evaluation at the end of the presentation. I've also shared an ACME link in the chat now for those interested in ACME credits. So now I will hand it over to you, Dr. Kruse. Thank you.
Thank you, Mr. Pond. And is it correct that we only have one participant now? Is it Dr. Cooper?
That is correct. However, people may join as you're getting started here.
Oh, okay. Well, I am happy to start if you want me to do that. It's nice to meet you, Dr. Cooper. It's I thought I would see my chief and maybe Dr. Canaca here as well, but I'm sure they're gonna drop in as we go. All right. So I'm a resident working for UNMH. I'm a second year, and this is part of the community track rotation that we do. And in that setting, we are asked to present a subject that that we have a high interest in. And initially, I had this presentation set up in a different format from before, but I added quite a lot of additional material to make it sort of applicable to the setting in which we practice here in New Mexico. So a bit of the background for me, I did part of my residency before in Sweden. And then I restarted my intern year here after doing 3 years over there. And throughout this experience, I have noted some significant differences and points of interest that I think might be worthwhile for practitioners to sort of widen their perspective, and also from a medical, legal, ethical perspective, see if there are things that we both could learn from one another. So yeah, that is sort of the topic for this talk, and I can see Dr. Fairfax Colombo tuning in as well. Welcome. So let's get going. See if I will be able to do this. Yeah, this is what I mentioned before. And as I mentioned, now I'm in my second year here at UNM. These are the instructions for getting credits for this presentation afterwards as well. And there are no financial arrangements or anything I need to disclose for this. And again, this is the disclaimer that these are the views that I present for myself and doesn't necessarily represent the views of UNM itself. All right, and specifically the learning objectives. I used the term used here is demographic, especially in terms of financial resources, and also maybe not the country itself, but for the major cities comparable to Albuquerque, a similar setting in terms of population size and also the overall societal economic resources. And the medical legal approach for both serious mental health and substance use, and discussing those differences, and then also the sort of legal approach to that same patient demographic. and we're also going to talk a bit about ethical considerations at the very end. All right, so this is sort of the structure of the presentation. So I want to give you guys some background information initially, and then it's going to sort of be set up by how the healthcare system in Sweden is structured, and it's not so much in structure because I think that's salient information for you guys already. Rather than I will focus on the differences on these medical-legal aspects towards the end. All right, so brief information about Sweden in general. We just passed 10 million in population. The majority of people live in urban areas. It's actually, opposed to many people believe, not a republic. It's a monarchy with what's mostly a constitutional monarchy at this point. And also one thing I wanted to highlight here is that they're traditionally these are sort of the ethnical composition of the country, but nowadays, it's a good quarter of the country is actually from another country of birth. In recent years, primarily from the Middle East. So we do see a lot of more diversity than people initially might think when they consider sort of the stereotypical image of Sweden. And I did do the per capita comparison, but on a population basis. Latest data I got here. I think this is from the World Bank, is 55,000 for Sweden, and New Mexico is actually closer than I thought it would be. It's looking at the U.S. Bureau of Economics, it's a few $1,000s less when you divide it by per capita. This is sort of my little brief overview about famous people in Sweden you might know. This is what all Americans think of when they think of famous Swedes. And just a fun fact, I had never heard about the Swedish chef until I moved to America. So that's why I put him here. But on another note, there are several sort of notable figures, both in medicine and sort of acting. We have ABBA here. We have the great actor Dolph Lundgren, and then Alicia Vikander won an Oscar a couple of years ago. This gentleman here is important in psychiatry, Berzelius. He did actually first describe the element. And this gentleman here is a rheumatologist who gave the name to the disease we know as Sjogren's in the US, but it's actually Dr. Sjögren in Sweden. And here we have Linnaeus, who is sort of the father of the botanical text. The 18th century, and this gentleman here is Alfred Nobel with the well-known Nobel Prize. And I thought it would be good for you to also see the actual head of state. So this is the King of Sweden. All right, next slide. I did add some sort of general cultural aspects. I think these sort of bullet points here are representative of it's a high literacy rate. A significant proportion of the population are college educated. Currently, it's less than 0.5% that are homeless. About a few thousand of those are acutely homeless. And there are some sort of on a population basis, for at least for the New Mexican perspective, some tight regulations on both illicit drug use and alcohol. You cannot purchase alcohol on Sundays at all, except for bars. And THC and cannabis use is illegal. And if you get caught repeatedly with small amounts, you can also get a prison sentence. So I wanted to highlight this because we are considered kind of like a liberal society, but in terms of substance use regulation, there are definitely some legal conservative aspects that might not be that well known. All right, so this is when I was initially preparing this presentation, I only had data for Sweden and the United States. Asked me if I could also include data for New Mexico, which was interesting indeed. There was a couple of points here where I couldn't find the same data that I got from the WHO. But the data I did find was quite interesting. As we sort of see a general trend in terms of life expectancy, that Sweden has slightly higher than the US overall, has a few years lower, but it's further decreased, especially for men in New Mexico. And if we sort of break that down, especially with regards to alcohol per capita and suicide mortality rate. And I actually looked at more recent data for New Mexico, and these numbers have actually continued to increase. So that's where a significant portion of that mortality lies. And then I didn't have this at the bottom, which I looked into, but in terms of the opiate related deaths. So this number for Sweden is actually quite high in a European setting. It's among the highest in Western Europe. But then if we go see, this is very reflective of the ongoing opioid epidemic that we see in the US, and also, of course, New Mexico being especially hit hard by that. So this is sort of kind of the numbers I was thinking about beforehand, but actually finding out what it was, what it actually was very informative, and seeing this sort of trend overall over several different strata of data. So I just wanted this. I don't want to spend too much time on this. This is sort of more knowing how in a sort of universally based healthcare system that the healthcare is set up and provided in different entities. What we have here is that it's of course regulated on a governmental level, and there's and it's one of 8 like sort of general government agencies. And healthcare itself is actually a specific subdivision that is separate from both the local and sort of state governments. So there's another political sort of level, which divided the country into 21 different county councils that are directly funded by government allocation funds, and they need to keep their own budget, which they never do. But then what makes it a bit complicated is that we do have, apart from that, 290 municipalities, which would be more akin to actual US counties, or like maybe cities. And in terms of disability care and elderly care, it's actually that sort of administrative body that has responsibility for these aspects of healthcare. So we have to, especially in psychiatry, we have to have a lot of overlapping communication between different administrative bodies, which is not that different from what you see in the US. And that just because it's a universal healthcare-based system doesn't necessarily mean that there's not a lot of bureaucracy involved. This is sort of the same slide, but more subdivided. And I don't think we necessarily have to go into this. It could be worth mentioning. This is a few years old data, but 70 hospitals overall in the country, and then about 1,100 primary care facilities. And it used to be that dentists were part of this too, but now it's moving more and more towards the private sector. All right, so this goes well with the Christmas theme here. The primary healthcare covered, I think this data is from 2016, so they covered a fifth of the healthcare budget and 16% of positions. It's an interesting figure because it's actually a sort of healthcare goals coordination documents. This figure is supposed to be, but I think it's representative of that the sort of political and organizational push of healthcare doesn't always coincide with what medical professionals eventually choose to go into. And I think this would be, and when I say 16% of positions, this would be sort of the equivalent of a US family medicine practitioner or more overlap with a GP in the UK or Australia. And then, this is sort of the setup in the sort of base sort of gatekeeper function of the healthcare system is in these family medicine practices, but they also, by regulations, have to constitute sort of a wide variety of baseline functions of care. So we see actually a lot of the psychiatry is directly being provided in family medicine clinics. So that includes that they hire often counselors and psychologists as well. And also they have, there has to be some competency in OBGYN and ophthalmology. So it's structured in a way that people having this as a sort of a first line before referrals can be sent and seen and being able to see a specialist. Oh yeah, I put this is an interesting figure. I think people might find this interesting, that this designation of private is actually, it essentially means that the clinic operates based on funding allocated by the sort of regional councils. That's ultimately also taxpayer money. So it being private doesn't mean that patients insurance or out of pocket. It means that it's private companies who run it, but they get reimbursed still by the tax dollars. And this is becoming more and more of a lucrative business. I would guess that this figure is probably even higher today. All right. Oh yeah, and also said this, a substantial portion of what the primary care clinic does is home visits. Of course, this has been changed. And then a bit about inpatient care. I mentioned this before. This is the same sort of designation. So you can see on the inpatient side, these sort of entities are a much lower portion than it is on the outpatient side. And these are sort of the equivalents of US academic MD centers. So there's 7 of those throughout the and just sort of a representation of what your out-of-pocket fee will be. I think this has probably increased to 150 Swedish kronor, which would be closer to $20 in today's exchange rate. So that is sort of the maximum fee and would have to pay out of pocket for one single hospital night. But that also caps, see if I have that information here, but I believe that caps around a couple of $100 that anyone would be charged as a maximum for inpatient stay. And this is sort of how the reimbursement is structured for inpatient providers. So I added this bullet point here mostly to still say that we do have to do coding. It might not be as extensive as it is here, but it is a significant part of how the hospitals themselves sort of get allocated funds from these regional city councils is by complexity of diagnostic coding. So, so this could also constitute when you do this gatekeeper function with the GP/family medicine clinics. Then if you do get a referral, you do see a specialist in that, and those fees are actually kind of the highest patient fees that anyone would have at a given point. This would be closer to about $50. And it also caps after a couple of visits, and this is also a similar form of reimbursement as we see from the inpatient side. All right, so a bit about drugs. So this is also a public sort of insurance model where you actually have to pay up front for any type of medication up until the first 1,100 kronor. So that's around $140 US. But on top of that, every sort of medical purchase will be covered by the national healthcare And typically drug costs that I see here, especially in terms of like newer antipsychotics, are significantly less. And I think it's because like it's all these regional councils go together when they negotiate with pharmaceutical companies. So when we decide to buy in, for example, cariprazine or any other newer antipsychotic, it is still going to be more expensive than other options. But I think I've never seen a patient being charged for a single medication more than $70-80 in psychiatry, that is. But this is the benefit of the sort of single payer model here, is that it will still cap. So we might end up in situations where it's expensive for the first couple of times, but after that, there won't be a problem. And there are mechanisms working with social workers to cover these initial costs for people who are in socioeconomic hardship as well. Oh yeah, I think I sort of misnumbered this. So I think this maximum the maximum out of pocket payment is indeed a bit higher, and I think this might be for a 2-year period. I added this data. And yes, that is also, and under that umbrella is also what is being covered for any minors below 18. And yes, I also added this here because there are some limitations to this model. Essentially, when it comes to really sort of high cost, newer, very specialized drugs that might not be covered under the healthcare plan, are some case examples of people sort of falling outside of that, and where the insurance does not cover. But those are far and few in between, as you can imagine. Okay, so this is, oops, I added this slide sort of like how do you know with this insurance model who is actually covered by the healthcare system? So it's actually tied to what is our social security number. So if you have the equivalent of residency and of course citizenship, then you will get allocated this number, and by that you are covered by the national healthcare insurance. What's important to know is that all children who are physically in Sweden, so every individual under the age of 18, no matter their immigration status, will be covered as well. So the exception to the rule will be adults that are not enrolled in this system, and if they don't have, if adults are from a third country that is not under the sort of European Union general cooperation area umbrella, so this would be applied to Americans as well. They would not be covered unless they have their own travel insurance. So this, of course, will apply for undocumented individuals. But what has been decided is that physicians themselves, and this is kind of a hardship, but for individuals who are not part of this national healthcare umbrella, if they present with is not an urgent medical matter, it's not, the threshold is not life-saving. The legal wording is care that cannot be deferred. So example is maternity care is always going to be included in this. That has to be provided, but it's actually up to the individual clinic, and often what the clinic heads are going to do is they're going to ask the individual physician to motivate if that the care they are provided is care that cannot be deferred. So as you can imagine, that can be a very broad definition, and if you have like sort of an altruistic view of wanting to help people, you're going to see a lot of creativity in this in this section. So that is sort of how that is, how the insurance coverage is structured. Okay, what is covered? So the aforementioned primary care, and then the inpatient and outpatient services. Also emergency care. So if you go to the ER, I think the highest bill I ever got has been about 20 bucks. And it might be a bit higher than that, maybe 25 now. But that is also capped. And then the aforementioned drug pharmaceutical policy. And it's also importantly, mental health care is a designated sort of special care. So also in this, we also include intensive outpatient treatment programs, sort of longer affiliated rehabilitation facilities. In that case, there are also private options that you would have to pay out of pocket for, but the majority is still, if they're not directly run by public institutions, they get this funding from them. Yes, there's also a social disability act that is also the healthcare policy, and then again, this term care that cannot be deferred. Nursing home and long-term care facilities. So this would be sort of the equivalent of skilled nursing facilities. Also covered, and hospice care. This is all, like, the caveat here is also, as with everything else in terms of availability. So there might be long wait lines here, and there might be priorities that have to be made based on medical urgency, but it's not going to generate an and yeah, so this is an important exception, is that when I got to the US, that was actually the first dentist since my early 20s, because dental care is only covered up until the age of 20. After that, you do pay out of pocket for dental expenses. So that is one area in which there has been sort of structured the private healthcare insurance for adults. And that can be, if you don't have that and need dental surgery, that can be quite expensive. So this has been sort of a contention that this has not been covered, at least in the past 20-30 years. And yeah, this is some cost examples. If you are, oh yeah, I did forget to mention, up until this age cap in your early 30s. There is a coverage. There is a coverage at these numbers here. So I think these are still valid. So this would be sort of the main cap, $1,600. After that, the national insurance would cover. It's only up until this age. So we still have a significant portion of the adult population that would not be covered. Okay. So this is how the funding of the public healthcare system, where it comes from. So these, when it says taxes here, that is actually referring to direct sort of regional council taxes to these healthcare authorities. That's a separate sort of on the tax bill, and these would be sort of the equivalent of federal taxes in different subgroups. So as you can see, it's a very small portion of the cost of the healthcare system that's covered by these direct patient fees. And yes, this is important as well. I mean, I think it's wrong to call this federal government, but the government will because it's not really a federalist system, but the central government will redistribute to these regional councils, because the tax revenue from different regions of the country might differ quite substantially. But it's sort of ingrained into the legal system that the quality of the healthcare cannot differ substantially. And sometimes, of course, it will differ, but not to the extent that that the funding will be significantly different. So it's sort of this Robin Hood redistribution that is baked into the system. Right. Okay, so this is the example where we have the cap for all healthcare visits. So this includes emergency visits, outpatient visits, and also specialty visits. So this is probably has been increased by, I would guess it's now around $150 US. But it does not, but then relating to pharmaceutical cost, it was the other sort of structure I was mentioning. So I think when getting it all together, an annual sort of cap of all outpatient costs would be between $350–400. And yeah, as I mentioned before, if you're under 18, you're not part of this charging models. And these are some cost examples for what you could be charged in different settings for these different services. Okay, so now we get into healthcare, mental health care. So this is actually one of the inpatient psychiatric units that I trained at when I was in Sweden. So it's quite different, sort of, at least the clinic I was associated with have sort of a different philosophy in terms of inpatient psychiatric care. You see overall much lower acuity, and I think the model is framed that there should be a more long ongoing recovery process. So a lot of the mental health institutions will be in settings like this. So this is quite far outside of Stockholm in sort of a natural environment, and patients always go for walks. A significant portion of my job as an intern was to do safety assessment if patients are safe to go out with staff, if they are safe to go home on leave. A distinction when there's not going to be much liability around this is also that we rarely discharged a patient from the inpatient side before they had successfully been able to leave and stay overnight at home at least once. And here are some figures. So this is the patient rooms were not this nice when I was working, but they just opened up a new hospital before I left. So this was sort of their promotional pictures of what a typical patient room would look like. So this is sort of the distribution of psychiatrists. I actually didn't have this until last night, so I sneakily added it in. And the only source I found was a few years old, so this might be different now as well. It's quite significant comparing 11 to 18 per 1,000 in terms of psychiatrists. But it's importantly, Sweden faces the same challenges with a lot of psychiatrists reaching retirement age, and the sort of the bottleneck of the residency programs will not cover that a deficit in mental health care providers as it is here. So this number, it pertains to being seen directly by a psychiatric provider, and it does not include the percentage of the population that so will have been seen in this in family medicine clinics. That usually constitutes panic disorders, mild to moderate depression, bereavement, adjustment disorders, sort of that baseline of psychiatric conditions that the philosophy is that a general practitioner should be able to prescribe an SSRI, maybe switch to an SNRI. There are opportunities for cognitive behavioral therapy should be included in most of these settings. So if it cannot be taken care under that sort of baseline segment, they will see a psychiatric specialist. So that's an important distinction, because as opposed to the US, you unless you go to a completely private practitioner, you have to reach a certain threshold of acuity to even be able to see a psychiatrist in the first place. Even so for most people who fall into this like sort of middle class strata, they seeing a completely private psychiatrist or therapist is quite pricey. So most people will not opt to do that, and it could be frustrating for patients because they do want to see a behavioral health care provider maybe right away, but that doesn't necessarily mean that their condition will meet the criteria to be able to do so. All right, so this is at least some promising data here, because there has been a quite significant expansion of psychiatric residency spots in the recent years. So it's a good quarter of the actively practicing psychiatric population is now in training. But notably, the training, this number seems inflated as well, because the training is longer. It takes 5 years to complete a psychiatry residency program. And that is actually on top of having your general medical license first. So after you graduate from med school, you need 2 years of general training to obtain your license. And then in addition to that, it's 5 years of what we call subspecialty training. So the structure is different. And yeah, so this is a problem that we see here too. Inpatient beds have not been expanded, and even though we see an objective need in society, the sort of policies have meant that we do tend to see a shift where we have higher acuity for inpatient beds, as opposed to the model in which this system was initially created. And just like looking at the population increase over the last few years with the same number of beds, that becomes evident, not even looking at the mental health care needs. So this is of course going to be a huge challenge in the aftermath of the pandemic as well. And this figure I thought was important. So even though we see more acuity, it's still a minority of patients that are treated on an involuntary basis. So I did want to actually go into a bit what the sort of legal framework of involuntary care is. And I found this information booklet in English, which I found very, very intriguing, because they chose to translate it to compulsory psychiatric care, which is more in line to something you maybe have to do in school if you to graduate. But in this setting, we talk about psychiatric care. So the legal sort of framework in which this exists is quite different. We don't have, for initial hospitalization, the legal standing that you have to constitute a danger to self or others. That does exist, but for some reason, the lawmakers decided that should only apply if a patient asks to be discharged. So if they're already hospitalized under a voluntary setting, in addition to these criteria I'm going to go through later, they also need to be a danger to self or others. But to actively hospitalize someone when they present to the emergency department, or if you do a home visit evaluation, they don't need to meet that threshold. So the legal criteria is serious mental illness, which is actually not a specifically defined term based on diagnostic. It's a legal term that you would argue for in court, essentially, based on your overall assessment. Also, this should be not care, it should be inpatient care. So inpatient care is required 24 hours per day, and there are no sort of alternative options based on the overall presentation and overall circumstances of the patient. And they also has to refuse or, and this is important, be unable to accept care voluntarily. So if, for example, if someone is disorganized, if someone is significantly manic, we can use this argument. Even if they say that they want care, we can state that because of the ongoing mental health disorder that they're presenting with, that they cannot make, essentially have capacity to make that decision. And here is an important distinction. So this sort of, when you do the assessment to see if a patient meets inpatient hospitalization criteria, that can be done by any provider. It doesn't have to be a psychiatrist. As long as they are licensed as a licensed physician, they can write this initial document, but within 24 hours, they have to be seen by a psychiatrist who has not just training to be a psychiatrist, but has a psychiatric license. As a specialist, they have to assess it within 24 hours to determine if they still meet these criteria. So it's always a dual assessment by two different doctors. And this is, and then there's a second component, and this surprised me actually coming here and I guess that alludes to privacy rights, but we have said that taking away someone's phone or not letting them use the computer or also not letting them leave the facility are considered additional infringements of liberties. So if you want to do that, that has to be sort of entered as a separate legal decision, and you have to motivate why you want to do that. So just because someone is hospitalized involuntarily does not mean, but per default, that you can't take their phone away or you can't let them out. Those constitute separate legal entities that you apply for, essentially. And interestingly, this also applies to restraints policies and injections. Those are two separate sort of legal distinctions. So you can't, technically you can't even medicate someone and put them in restraints if they are there voluntarily. But from a practical standpoint, if that happens with a voluntary patient, of course we would convert them at that in that setting and then do these interventions. All right, so this is something I wanted to add. So this is actually a pretty significant part of what we would do in the outpatient setting. There is sort of legal leeway to provide what we call outpatient involuntary care. And to meet that criteria, patients have to have been involuntarily hospitalized initially. And then you have to, after the initial hearing where that is confirmed, you have to apply to the courts a second time and ask for that the involuntary care will also continue in an outpatient setting. So it's not something that can be transferred while the patient is at the outpatient clinic. They have to be hospitalized first. And the sort of involuntary basis for outpatient care always have to include defined conditions, and most often it relates to LAIs. And this is another sort of example where our system is more conservative. It's often it could also constitute having to provide negative UDMs for substance use treatment, which in this setting here is a lot more controversial. But maybe not the aspect of getting an. But not just that. We try to adopt more holistic sort of framing to keep your visits, to allow case managers in, to partake in psychosocial rehabilitation could be part of that too. And so what happens if, for example, patients do not show up to the LAI appointment just once? Then you don't have to do the full sort of legal paperwork again. You don't even have to assess the patient. You can just file out a brief document stating that the patient has to be re-hospitalized to be able to meet the criteria for which the outpatient involuntary care is being set. So there's some flexibility here when you sort of push that button and initiate this sequence, but it can be pretty substantial in case patients miss their LAI for a week, and there are reports of that patient is deteriorating, is decompensating, and then you can preemptively sort of get them back into the hospital and get back on their treatment plan. Okay, so this is one thing I wanted to sort of highlight here, and it alludes to this is actually the formal translation of the patient material, which it's framed as care of substance abusers, which I think says a lot about sort of the mindset. But what I think is interesting in sort of the how the law has been designed is that there is sort of a segment here in which we are being able to provide substance use care for patients who do not wish to receive it. And this is in a way more separated than the mental health care I was mentioning before. This cannot be determined by a clinician. It has to be approved by a court. All right. And what that means is that this is how it's formally supposed to happen. I don't always see that is the case, but if you have a patient in front of you where you determine that the ongoing substance use is putting their life in severe danger or the life of others in severe danger, and this is sort of the legal framing, it's an obvious risk of destroying their own life. So that could mean losing their job, losing their relationships. And this is more like alluding to medical risk. Then you are mandated to file a petition to the court for them to assess the patient, and if they have to have a hearing, and if the hearing is approved, they are mandated to substance use treatment, which is confined, but it cannot last for more than 6 months. And there is varying. I was reading some data. There is varying success. So this is sort of a representation of how bad you have to be in practice for this to be implemented, because this is sort of the estimate of patients in the country who meets criteria for severe substance use disorder or alcohol use disorder, and it's only a small fraction of those who actually will be going to rehabilitation under this law. I think it's important to notice what I've seen in practice is this tends to focus, the courts tend to focus on younger individuals, sort of who are in early stages of their substance use, and prioritize them to get these sort of interventions, as that is considered some more likely to change a bad trajectory. All right, so here is a slide sort of denoting the more like side-by-side comparison, and this is what I mentioned before. So here we do not have the danger to self or others or involuntary admission, and I was very grateful because Dr. Fairfax Colombo, he informed me that there is indeed a mechanism for involuntary outpatient care that has been started by the district courts here. But as of now, there is no active provider. And I was actually reading the outline of this New Mexico law, and it is quite similar to the law that exists in Sweden as well, where the courts have to scrutinize these separate conditions for which the outpatient care should happen. But I think it's definitely a step in the right direction. And I think just being made aware that this exists is interesting indeed. And here we do not have a mechanism for involuntary commitments of individuals with substance use disorder, even though that could potentially form a basis for guardianship. But my impression of that is that the condition must have deteriorated quite significantly for that to be considered. And this I noted, whoops, sorry. And this statement here, the mortality rate for suicidality is similar when looking at the US overall for Sweden, but looking at New Mexico is still high. And looking at the drug-related deaths, both in the US and then even more so in New Mexico, that continues to increase in comparison. So this is sort of what I wanted to highlight for sort of the ethical considerations here. I think I'm starting to run out of time, so I apologize. But when I was looking into this presentation and wanted to discuss in terms of ethics, of course, what's going to be present is mostly going to be sort of qualitative studies and qualitative data. And there are several sort of ethical theories, but among the publications I was reading is that when looking at autonomy as sort of a pillar of ethics, these pillars were not construed within the mindset that one of them should be more important than the others. It could be argued that looking at these two systems side by side, it's pretty evident that the autonomy is being more highlighted here than it is in Sweden and many other places for that matter. And also looking at the pillar of beneficence, like doing good. All right. I did, and this is an argument that I've heard many times throughout my upbringing, is that the sort of notion of doing good doesn't necessarily just apply to the patients or the patient's immediate relatives, but also that society as a whole has an interest, is a stakeholder in the care of a patient. So theorizing that taking care of this patient and giving them treatment is also important for our society, our collective society. All right, so why does this exist? So I noted here, I don't think it's just an allocation of resources issue. We have a very strong trust in sort of public institutions overall. Even if I've seen this being more and more eroded, it's definitely significantly different than here, that you have a public trust in not just healthcare, but also government apparatus, government institutions, that sort of these things exist to advocate for you and they work for your interest. And this is what I alluded to before. So I think it's more in the common mindset as well that these laws and these interventions are accepted just because you need to do good for society as well. But then I see bad aspects too. And when I come here, if you are able to establish a therapeutic relationship, I notice a much lower threshold for patients to disclose sensitive information, both in regards to substance use, sort of legal interactions. I think there's more fear in Sweden, working in Sweden, for patients to to not disclose drug use, to not disclose prior decompensation, and overall being willing to share information because they know that clinicians have more power to sort of get to these involuntary measures. So I've definitely seen examples of that as well. And then I just made these bullet points here. Sort of course, the health data is dynamic and there's multiple factors going into it. My initial intent of doing this presentation was much just highlighting the differences and maybe sort of let this information sink in with the audience. What this means, and then Dr. Fairfax was pushing me a bit, but you have to tell the audience what you think about it, and I do think I'm actually not entirely sure about the mandated treatment we have for substance use disorder, but I do, working in PES and see these acute decompensations, I do wonder sometimes if we could prevent a lot of cases of continued illness, continued deterioration. Because what I see often is you have someone with might be active psychosis, severe mania, and you know that this is likely going to deteriorate to a point where they are going to meet criteria for inpatient hospitalization, but does not do it at this current point. So I think in helping our patients, having a legal groundwork that is similar in that regard might be beneficial, actually. All right, and I think I've been probably going on for the full hour here. I do apologize. I do not know if we have time for questions, but I am very happy to answer questions if we do. All for coming and listening to this.
Thank you so much, Dr. Kruse. We'll just give it a second here to see if any questions come in, and then I will sign off the presentation.